Other control risk factors, what's called carotid artery stenosis, which is a narrowing of the arteries in your neck, has to be greater than 70% and on the side of your stroke. So if your stroke was on the left side of your brain, so your right side is affected, but the left brain is affected, it's the left artery that they're talking about. So if there's greater than 70%, then there's evidence that surgery is beneficial, and either they go in and they just actually clean the artery out, or they may go through your groin and actually put a stent to push back the plaque. A lot of times people will be on statin medications. There's some evidence that the statin medications will actually act almost like an anti-inflammatory and prevent the cholesterol formation in your neck. So a lot of times if people have narrowing of the arteries, the doctor, if you've had a stroke, will automatically put you on something like atorvastatin, maybe 80 milligrams. Hypercoagulated state means your blood clots prematurely. So some person can have an inherited protein deficiency. Medication, birth control pill, estrogen, increases the blood clots, can increase the chances of developing blood clot and having a stroke. Cancer itself can increase your, the viscosity of the blood and make it thicker, and more people are likely to have stroke. Treatment, someone might be on salicylic acid or aspirin, someone might be on warfarin. Sleep apnea. Sleep apnea is often the situation where people stop breathing during the nighttime. Maybe if your spouse or someone says, you know, my husband or my wife stops breathing during the nighttime, and then they wake up and they kind of, you know, start choking particularly. The person's unaware that they wake up or that they're stop breathing. Often it's somebody else who will notice that their breathing is a problem. But we do know that with sleep apnea, it is a risk factor for a stroke, particularly not treated. And if you've already had a stroke, it's another risk factor. Treatment, often people might be overweight, so weight loss is important. Or they might be on a machine called a CPAP machine, which basically blows air into your lungs. If anybody watches Mike and Molly, which is a TV show, he's got sleep apnea and he wears this big mask on his face, so if you ever want it, that's what he's got. Stress. There's a link between stress and stroke. It's not a proven factor because there's so many things that can be influencing, but we do know that job stress in men has been associated with stroke. Someone has difficulty managing anger, or stress. So, you know, you get mad every time someone pulls in front of you driving a car or that kind of anger. There might be a link with that in eventually having a stroke. So if someone is stressed, often it's the behaviors that happen after the stress. Overeating, smoking, and drinking. Okay. That's the first part. Okay, everybody doing okay so far? I know it's a lot of information, but if you have any questions at the end, we'll talk about it. That's why this is the continuum, that we're going to talk about all different things. Okay, so if someone's had a stroke, this is when we talked about risk factors and understanding symptoms of a stroke and the importance of knowing the symptoms. There is acute treatment for a stroke, and which actually I'd say is actually a cure for a stroke. So if someone has problems with speech problems or weakness particularly, and you get to the hospital in time, there actually is a cure. Maybe cure is the wrong word, but I'm going to say cure right now. So it's a clot buster medication called tissue plasminogen activator, or TPA. The only place they do it in Niagara is Niagara Falls, or GNGH. That's the stroke center in Niagara. The original study looking at TPA found that only about 5 or 10% of all strokes were appropriate for TPA. Reasons why are some of them were bleeds, so they couldn't get TPA. Some people didn't get to the hospital in time. Some people had, there's certain criteria like if your blood pressure is too high, or if there's certain changes within the CAT scan, the person doesn't get TPA. So 5, 10%, maybe a little bit more. If there was all the education and everybody knew all the symptoms and did exactly what they're supposed to, it might go up a little bit higher. But a lot of times people may go to bed feeling fine, and they wake up with some weakness or numbness. And when that happens, you can't get TPA because you don't know when the symptoms started. It could have started 5 minutes before you woke up. Could have happened 6 hours before you woke up. So a lot of people, as we talked about what mimics a stroke, oh, I just pinched a nerve in my neck, or it's just anxiety, I'm a little bit anxious today. So by that time, you know, you're outside this window. The window used to be 3 hours. There's a little bit more evidence now that may actually say 4.5 hours. EMS, so the emergency department, if you call them and say, you know, I think I'm having a stroke, or my husband or my wife is having a stroke, they'll come to your house or wherever you are. They have a certain scorecard, basically, that they will go over and look at what's happening to you, and they make the decision whether you're in the window. Now, I think with the EMS, I don't think it's 4.5 hours as a window yet. I think they're still circling more towards the 3 hours. I'm not 100% on that one. Is it 3 hours still? They may work on trying to change it eventually, but right now it's the 3 hours thing. And if they believe that you're in that the window, then they'll take you right to GNGH. So whether you're in Fort Erie or Port Colborne, as long as nothing else is going on, they'll take you right to GNGH. If it's outside the window, then they'll take you to your closest emergency department. So wherever you are, they're going to take you there. So that's why it's important to know your risk factors and know the symptoms particularly. Know what is significant of a stroke. I mean, I think a lot of times when people have symptoms, oh, it's not a stroke, I'm not going to worry about it. I don't want to bother anybody, I don't want to sit in an emergency. Well, if you really did have a stroke and you get to emerge and it's within that window, they're going to get you through. Meaning they need a CAT scan within so many minutes. They need to be able to do things very, very quickly to investigate you, because if they go too slow, they've missed the window and the person doesn't get TPA. So I mean, a person can go in with complete paralysis on one side, typical speaking, they can get TPA and they can actually walk out of the hospital. Not for everybody, but I mean, there are situations where people have kind of like a complete cure. And we see people even at Shaver who have come in for rehab who got TPA and they've done very, very well, and they've been able to, they have minimal deficits. If they didn't get TPA, who knows, they might have severe deficits, they might be wheelchair bound. Another acute treatment is what's called a thrombectomy. I don't believe they're doing them in Canada. I don't know, maybe people can correct me. I know in the States they're doing it. Basically what that is you have a stroke and they actually go in through your groin, go up to the brain, and actually can pull the clot out of your brain. Okay, so there's no medication. They might still get TPA, but actually they can actually pull the clot out. And imagine that with time, that's probably going to be something that's going to be coming more, is that there's going to be actually this being able to remove the clot, which is actually quite amazing. So before it used to be, I had a stroke, nothing I can do about it. You come to rehab, which is nothing wrong with that, but the idea is that people you've already had something bad has happened to you. But there is acute treatment for people, and people can, I think cure is maybe the wrong word, but the idea is at least your deficits can be minimized. If you're not appropriate for TPA, then you're talking about what else can happen to me. So if you're looking at natural recovery, so if you had a person has a stroke, what can you kind of expect to happen to the person if you don't do anything to them? And I'd say natural recovery. Okay, this is just what kind of happens to you. So and if you have a family member who's had a stroke, things you need to look at, these are the good signs to show people are making big gains. So the most rapid recovery is in the first 6 weeks. So that's why it's important getting people to rehab fast, because that's when they're making the biggest gains. If you wait too long, then you've lost a lot of the time where people can make gains. Majority of improvement is usually seen by 3 months. A lot of that's motor recovery. Okay, so that's moving your arms and legs. Speech and cognition might take a little bit longer if that's been affected from a stroke. But you can still see recovery after a year. Doesn't mean they're in rehab all the time or they're receiving therapy, but you can still see changes. Family and patients are always reporting that they're still making some gains. So I never tell people, have I reached my full recovery? I mean, from an insurance point of view, you might say yes, but from an individual point of view, I don't think I ever tell anyone they've reached their full recovery. Prognostic factors. So what makes it a good sign? Younger age, and it makes sense. The younger the person is, less medical problems they have, the better they'll do in recovery. And stroke severity, the bigger the stroke, the more deficits, the worse the person will do. Okay, so I mean, it makes sense. If you have a mild stroke, you're probably going to do better than someone who has a major stroke. From a rehab point of view, mental status or the ability to learn, your thinking is very important. If the person can't learn, they're going to have trouble participating in rehab. So if you look at someone who's had a stroke, these are kind of a breakdown of what the kind of deficits the person has. So if someone has a stroke, about 15% of people will die. 10% will completely recover. Okay? And that doesn't necessarily mean we're not talking TPA here. This is just talking about stroke itself. Sometimes people have mild deficits and they'll improve. 25% mild deficits. I put outpatient rehab. Maybe that might be a group that goes for outpatient therapy. 40% with moderate to severe deficits. Often they will go like inpatient rehab, and then they might go outpatient afterwards. And there might be about 10% are severely disabled. It doesn't mean that they won't make any improvements, but even with all the rehab that you can give them, the person just will not improve enough to change their ultimate destination where they're going to go. And often a lot of people will end up going to a long-term care facility. Again, these are just an estimate, basically. It doesn't mean that everyone's going to fit to this. In 2000, there was a group of experts who looked at rehab. And this is what their consensus was. And you guys can decide whether you think this is happening or not. I don't want to see it. I don't want to see hands. So individuals who experience a stroke will have timely access to the appropriate intensity and duration of rehabilitation services. These services will be provided in a comprehensive and coordinated way to patients and their families by agencies and healthcare providers who are an expert in stroke and practice rehabilitation principles. That's what the goal is across Ontario, not just in Niagara or Toronto or Hamilton, across Ontario. Some things have happened, but in 11 years, some things haven't happened. So what actually is rehab? So rehab is defined as more of a progressive, so it's something that you're building on. Dynamic, so it's active and you're not just sitting there waiting for recovery to happen. Goal-oriented, so often the person wants to be able to, I want to be able to go back driving, or I want to be able to walk 100 meters, or I want to be able to feed myself. And often a big complaint is that time limited. In two ways. Time limited meaning the fact that people will recover to a certain point and then stop recovering, and also the process of rehab. There's a lot of people having problems. There's only so many therapists. Unfortunately, people, programs end 8 weeks, 6 weeks, whatever long it's going to be. So with rehab, you're looking at trying to get the person to reach their optimal or their best physical, cognitive, or social functional level. You're trying to reduce their limitations or disabilities, so what they can't do, and improve their participation in the community, or getting them back into, or reducing their handicap, getting them back into the world. So rehab starts right from the beginning if someone's having a stroke. It's getting the person moving as soon as possible. So it's getting the person up at the side of the bed. It's getting the person to the washroom to be able to, instead of just going to the washroom in the bed, trying to get them up. You're trying to improve functional outcomes, so you're getting the person to do more of their things for themselves, brush their teeth or feed themselves. You can working on transfers, getting the person walking. You want to get these people doing things as fast as possible. As we know, the biggest recovery is in the first 6 weeks. So you want to get things started early. So hopefully the person's going to feel better, they improve quality of life. They're not going to just be sitting in the hospital waiting for someone to do something for them. Hopefully this is something that's going to be built on. It's going to be everybody. It's not just therapists, it's nurses. It's everybody who's participating in the rehab process. And rehab can be given to people inpatient-wise, so in the hospital, outpatient, home care, private therapy, community agencies. They sometimes have certain kind of rehab, and home. Okay, we're not talking about which is better than others. It's just that they can come from different places. Okay, the little picture on the top is supposed to be a synapse, or which is basically where your brain connects. Okay, where all the impulses, the little brains or sort of nerves in your brain, the communication between the nerves. Okay, and then one of the big things in rehab is, why do people get better? And part of it is what's called brain plasticity. So the brain functions on the number of connections there are. So the more connections, the better you're going to do. So if you have a stroke and these connections are disrupted, the person's going to have problems. Okay, this is important in rehab, is knowing about this whole idea about synapses. So a lot of the research into why rehab may work is done in animal models. You can't really do it with people, because often you have to kill the rats and do autopsies and stuff like that, so you're not going to have people do this. So what they do is they induce strokes in rats. Okay? Don't ask me how they do it, but they cause rats to have strokes. They can affect the same area of the brain, and rats have strokes. And they found that the areas adjacent, so closest to where the damage is done, has the greatest ability to change or to improve or to make connections. Okay? They've found that complex environments where these rats are in, they have greater synapses. So an example would be if they have a group of rats and they all have strokes, you put some rats in a cage, just a regular cage, and there's nothing exciting in the cage, it's just a cage. And you put other rats in kind of like a condominium kind of hotel thing that's got bells and whistles and running tracks on, and they can climb things, and it's a happy environment. They've actually looked at there's greater synapses or better connections in these people, in the rats that have had this more stimulating environment. And so you can see that being in a more stimulating environment and doing things, patients hopefully will be doing better. They've found that if the rats don't get into these environments soon enough, that they don't make the same recovery. So if you have a whole bunch group of rats and they all have the same stroke, and you have some rats get into this nice environment at maybe 5 days, some at a week, some at 3 weeks, they've found that the 5 days and the week, they do fairly similar, but they make gains. But the rats that are like 3 weeks getting into this nice environment don't do very well. They do not recover. So the theory also going on with humans is the same thing happens. If we don't get people into rehab soon enough, they're not going to be able to make the gains that they would if they got into rehab sooner. The one thing that does going into this, if you have a very severe stroke, so more deficits, that person will not, or that rat will not do as well in rehab. They need a little bit more time, so they might go into more of a slower paced situation. Okay, so if someone has a very, very severe stroke, if you put them into active rehab, they won't do very well because it's too tiring for them and they don't able to participate in gain for the person who's at a less severe.